attendees are in listen-only mode.
Good afternoon. Thank you for joining the We Can Educational Series. Today, Dr. Kristen Iniguez will discuss the role of the medical provider in child abuse cases. The handouts area includes a PDF of today's slides, as well as a PDF with details on the following housekeeping items. To ask a question, you can use the question pane on the control panel. Questions will be addressed at scheduled breaks. To obtain continuing education credits for today's session, you must track your attendance by texting today's code to the phone number on the screen. The code and phone number will be displayed at the end of today's session. After reporting your attendance, you should log on to your account at ocpe.mcw.edu and complete an evaluation within 10 days. To view step-by-step instructions on claiming continuing education credits and to see a list of future webinar topics, please visit wichildabusenetwork.org/webinars. Now we will proceed with today's presentation.
All right, good afternoon, everybody. My name is Kristen Iniguez, as Elizabeth said, and I am a pediatrician that specializes in child abuse medicine, working at the Marshfield Clinic in Marshfield, Wisconsin, and I'm actually the medical director and director of the Marshfield Child Advocacy Center as well. And so, as she already said, I'm here to talk a little bit about the role of the medical and the medical provider in cases where there are concerns for child abuse and neglect. But before we start, I have to throw up the disclosures or lack of disclosures, and so I have no financial disclosures to make today. So what I really want to focus on, or what I'm going to focus on today, is first, and I think for most of you, or for many of you, you're familiar with what a multidisciplinary team is, but I'm going to talk briefly about that approach in investigations for child abuse and neglect. But then I'll segue into the role of the medical and the value that the medical and the medical provider add to the investigations. We'll look at when medical exams should be obtained, and we'll do that through some case exploration. And then finally, looking at the importance of when to seek out expert medical consultation versus more primary care physician or emergency department or urgent care evaluation. So to start, again, I think many of you already are aware that an MDT, or a multidisciplinary team, is a group of professionals working together in a coordinated and collaborative approach to ensure an effective response to reports of child abuse and neglect. And I promise I won't read all of my slides, but that one is a little lengthy. And really, when the team comes together, they have a common goal, and that is to help provide protection for a child and also to ensure their overall health and well-being. And through the National Children's Alliance, which is the governing body for all of the child advocacy centers across the country, they have designated 7 professions that are part of that multidisciplinary team. There also are a couple other more ancillary, but we recognize that, of course, human services, law enforcement, the forensic interviewers, medical services, mental health services, the DA's office, and victims advocates are all part of that, that team that should be coming together in the acute setting to help pursue these cases. And really, we should recognize that each of these disciplines, the individuals coming to the table bring their own experiences and they bring their own expertise, and that we should be leaning on our relative experts to help improve our overall case outcomes. And so that's going to lead me into my talk about the role of the medical, because unfortunately, many times I hear from my MDT members or other MDT members that, well, you know, we decided not to get a medical. But in many of these cases, what I'll show you is that that really should be the medical provider's decision, or at least they should have a role in making that decision, because there are many pieces to these cases that you as CPS or law enforcement or other professional may not be thinking about. So again, the benefits of having that multidisciplinary team approach is that we obviously inflict less trauma on the child if we can pull them together, especially going through a child advocacy center, having the forensic interview, having a medical evaluation, all done in the same time frame. This real-time approach enhances information sharing. So when we're sitting across the table from our partners, we're able to give and receive information in a way that helps move those cases forward very efficiently and effectively. This will help, I think, in general, making agency decisions. And it's, again, a more efficient way of utilizing our resources in general. One thing I like to do whenever we're meeting as a team is we're always taking something away from our other professionals around the multidisciplinary team table. So we're always learning something, either about how the systems work or some sort of medical piece of information or otherwise. And then finally, really when we're working as that team, I think it helps us appear and be within the community that we are a whole team and we are working together and we are supportive of each other. And I think that helps the community have more reassurance about what we're doing in general. So I want to ask 3 questions today, or really, I'm sorry, I want to answer 3 questions today. The first question is, why should we get a medical evaluation? Why is this important to what I do? When should we get a medical evaluation? And finally, who are we going to seek that evaluation with? There are, again, multiple different professionals in our communities that can provide medical. So we have our primary care providers, we have emergency departments, we have urgent care providers, and then we also have our child abuse specialists, who is going to be the most pertinent person depending on our resources and availability to take that child to. But to start, we're going to focus on the why. What is it that a medical can provide for my case or my investigation? Why should I be bringing that child in for that? I think some of the reasons are very obvious, but we'll go through them one at a time. One of the things in an ideal medical evaluation that we do is a very comprehensive chart review. And so when I hear about a case coming into our Child Advocacy Center, the medical assistant that I work with pulls medical records from all over the state if necessary, and sometimes all over the country. And we're looking for, again, evidence of overall good medical care, but then also evidence of other types of injuries or previous injuries that could be suspect. We're then performing a very comprehensive, again, medical history taking with the parent or the caregiver if they are involved, and an interview with the caregiver, but also sometimes with the child if the child is developmentally able to talk about that. Now, of course, we're very cognizant of not wanting to get in the way of any kind of forensic interviewing, so our medical interviews are generally a little bit different than that forensic piece. Of course, injury identification, so when we're doing our physical examinations, we're looking for any signs of external injury, and that can be both in child abuse cases, or I'm sorry, physical abuse cases or sexual abuse cases, but even in neglect cases or drug endangerment. And we're also providing some pretty specific documentation, which I think is very helpful for cases as they move forward. And of course, in those cases where it's necessary, we can provide forensic data collection. That could be in the form of a forensic kit, although I tend to let our SANE nurses do that as they are the experts in that forensic evidence collection. But keep in mind that even though everything I'm doing has a medical underpinning or a medical basis, all of our workups are, to quote another colleague of mine, is that they're forensically sound. So a lot of the information that we gather might provide some medical information, but also can be used in a forensic nature. I think one thing that's very important with our cases and the way these evaluations should be performed is that most child abuse experts have a very standardized evaluation protocol. So it includes that chart review, the history taking, the physical examination, but then also we have very specific things that we're looking for or that we're asking others to obtain as far as laboratory and radiology studies. And we do this because we are, in many cases, looking to identify either occult injuries, so injuries that you can't see with the naked eye. We're looking for infections and other things that could support the case, but we're also looking for other medical diagnoses. We want to make sure that we're not missing something that can help this child with their overall health. In many cases, I know I'm asked to also review injury mechanism. We just had a fracture case in a couple of days ago and talking about what types of mechanisms could have caused that injury, or talking about what types of mechanisms could cause a patterned injury on the face of an infant. And last on this list anyway, and I'm sure very important for the CPS and law enforcement out in the audience, is that we're providing, again, a very well-documented written report that is something that is usually can be shared in the courtroom, and then providing that medical testimony when it comes to cases for either children in need of protective services or when criminal charges are being put forward. So of course those are things I think most of you are looking for, because that's going to help with a child abuse investigation and furthering that along through the process. But what else do we offer? And keep in mind that most of us who are doing this work are pediatricians. There's one other clinician in the state who is a family practitioner by original training. But that's what, we're trained in providing general care to children. And that is first and foremost on my mind, is making sure these children are healthy. So what else can we offer? We can help identify and treat other poorly managed or undiagnosed health problems. I've had multiple muscle myopathies diagnosed in my practice, which is rare and odd, but for some reason I seem to pick up on those. Obviously we're identifying children who have poorly managed asthma and helping with that treatment. And I'm going to give a case example here, I think on the next couple of slides about another case. We also assess for developmental delays. So we want to, a lot of the children that come on our radar, because of the environments that they're in, they are at higher risk for having developmental delays. They're at higher risk for having poor nutritional status. So we can do this through laboratory assessment as well as growth records. And we can assess for emotional, behavioral, and in some cases relational problems that the child might have in that home environment. Another big component of the exam for me is identifying other deficits in care. So most of the kids that are coming through are deficient on their immunizations. And if we really want to speak to their overall health, we want to make sure that we do maximize and we get them immunized. We also see a lot of children who just don't have a medical provider. And so we want to, if we can, if we have medical providers from our system in their region, we make referrals for medical homes. And we also make referrals for dental homes. I know that dental is a piece that a lot of people take for granted, and we don't think it's so important. But if your overall mouth is not healthy, it actually can make our bodies very sick as well. So we feel that that's a very important piece. Of course, we make referrals based on any of the findings that we have that require a referral. I've sent children to the cardiologist. I've sent children to the ophthalmologist, the nephrologist, you name it. And we have made that referral for the child, again, to optimize their health. And of course, for our children who are coming in for concerns for child abuse and neglect, we make a lot of referrals for behavioral health. We make a lot of referrals for occupational therapy. So that list is pretty extensive. We help provide education to not only the child, but the caregiver, because in many cases they don't understand what's happening. They want to know why it's happening, or if there are findings, giving them a better explanation of what those findings are and what they might lead to. And something, again, I think is also taken for granted is we're also there to provide a lot of reassurance to our families. Many times, in fact, in most cases for sexual abuse cases, our exams are normal, or at least there's no evidence of trauma or infection. And we can provide reassurance to the family and to the child themselves that they are healthy. And I've had children, usually preteen teenagers, who've actually come in wanting the examination because they want that reassurance. They want to know that their bodies are okay. Now, I want to tell you a little bit about a 9-year-old who came to visit us about a month and a half ago. And this speaks to identifying other medical issues within that child abuse evaluation. She came for concerns of sexual abuse. And really because the mother had noted that this child had begun masturbating more frequently, and also having what was initially described to us as new onset enuresis or new onset wetting, to the point where she was having to wear diapers again at 9 years of age. That's very significant. And unfortunately, this was causing a lot of issues in school for her. She was being bullied because obviously when you're constantly wetting, you don't smell very good. So When she had her forensic interview at the Child Advocacy Center, she made no disclosures of abuse or any kind of sexual contact whatsoever. So that started to raise a little bit of a question in my mind as to, is something else happening here? And when I did talk to Mom a little bit more and got more specific history, I found out from Mom that this child had never been dry. So for 9 years, she's never been potty trained. And so that again started me thinking that maybe there's a little bit more of an organic problem going on here. So when we did the physical exam, her exam actually was very significant. She had what we call an imperforate hymen. So if you're familiar with that, the hymen is the tissue that essentially is a rim around the outer edge of the vaginal canal. Her hymen completely covered not only the vagina, but also the urethral opening. And so when she would try to urinate, the urine would get stuck behind the hymen, and then she would just chronically leak. So what we did is we essentially found an explanation for all of the symptoms she came in with, the masturbation and the so-called enuresis, through a medical problem. And because of this, we got her into the gynecologist actually that day, and into the OR for what they call a hymenectomy to get her to essentially alleviate this problem. So really quickly, any questions?
No questions right now.
Okay, great. I hope that case kind of elucidated at least one example of why that medical, again, we can identify things that maybe we're not thinking about. And in many cases, again, we're identifying separate medical problems, but in this case, her medical problems spoke directly to the reason that she was coming into the center. And honestly, the CPS and law enforcement were ecstatic when they found out that this wasn't, more likely than not, was not a sexual abuse case, that this was more of a medical problem. All right, so moving on, the next question I have, and that I would like to answer for you today is, well, when should we be obtaining a medical evaluation in cases of suspected child abuse and neglect? I hear a lot of reasons from MDT members as to why they don't seek a medical evaluation. And so I want to talk about those through some cases. And I've got about 6 cases, so hopefully I can get through these in a fairly timely manner. But the first thing I hear is, well, the injuries were minor. It was just a bruise, a single bruise, or something very minor, and we didn't think that we needed to get that examination. When I first started here at the Child Advocacy Center, I actually had a 2-month-old male that was referred to me by his pediatrician. And luckily, she was very astute. But he had come into her office at 2 months of age, and she noted some very subtle bruising on his chest. And you can just make out these kind of green to brown lesions across his chest. And these were taken the same day, so these are real time. And so she called us. She wasn't sure what to do, but she thought something probably wasn't quite right, so she wanted us to evaluate. And so we were able to get him in very quickly, but in the meantime, we were able to do some really rapid chart review. So again, talking about that standardized protocol, I think this is important to point out, that when he was a month of age, so 1 month prior to this visit with us, he was seen in the emergency department for elbow swelling. Now, they did an x-ray at the time of that emergency department visit, but there was no fracture was identified on the x-ray. And he was discharged home without follow-up. So this is, so he came to see us, we did our general labs and skeletal survey, and this was one of the x-rays that came out of our skeletal survey. And what you'll see is that over here on the left, we have what we call periosteal elevation, and there's also on this side the hint of this little fluffy stuff is a hint of a fracture. So this child actually did have a fracture when he was 1 month old, but because it was so subtle and what we would call occult at that point in time, it didn't show up on the x-rays, at least that the radiologist could perceive. And so he was sent home, and my point to this is, well, the infant had elbow swelling, and so that should have been questioned as to why, especially if they had ruled out any kind of infectious process. But the completion of the skeletal survey also showed a couple of other things. So there were 2 rib fractures on this case. And so after we offered this information to law enforcement, they were able to go out and talk with the child's parents, and the dad did confess to very aggressive handling of this infant during his normal day-to-day care. And so that led to dad's eventual incarceration. So in this case, I think that the primary care doctor was very astute, but I think there are probably countless cases where these very subtle injuries get missed and don't get brought forward. And when I think about, I think most of us should be aware of Dr. Sheets' work on the sentinel injury, that whole phenomena essentially, and that any infant with even the smallest bruise really should raise concern for us to have that child evaluated. So I'm going to take that a step further. I'm not going to present Dr. Sheets' a study right now, but let's talk about the number of bruises, and does that really matter? Because again, I think most of us think that if there are lots of bruises, yes, that's concerning, but if there's only one or two, maybe it's not. So Dr. Harper and her colleagues published this study in 2014. They essentially evaluated 146 infants who were coming in real time, who were less than 6 months of age, and who had isolated bruising. And they were evaluated in a very systematic way and standardized way. Each of them received a skeletal survey and a CT of the brain. Many of them received a CT of the abdomen as well, and I believe there were also laboratories performed looking for bleeding disorders and the like. They also then surveyed each of these clinicians where these 146 infants were brought, excuse me, as far as their level of concern for abuse, and ranked this based on the number of bruises that were found. So the results of the study, again, they were broken down by children with only 1 bruise, children with 2 to 5 bruises, 6 to 10, and greater than 10. When they looked at the physician's level of concern, I think this makes sense, again, that as the number of bruises increased, the percentage of level of concern also increased with that proportionately, to where almost everybody was concerned when the child had more than 10 bruises, but only about a quarter were concerned when there was just 1 bruise. But when they looked at the ancillary testing, when they looked at the skeletal surveys, the CT scans, they found something really interesting. 60% of the infants with only 1 bruise had evidence of another occult injury. And only 50% of the children who had more than 10 bruises had evidence of another occult injury. So what this really, I think, drives home for me anyway, and I'm hoping for you as well, is that one single bruise can really make the difference for these children, especially these very young children. Another thing that I hear, and I hear this more so from clinicians, but I wouldn't be surprised if I hear it from MDT members at some point as well, but we hear that, well, the patient looks great. They don't need to be seen. And this is an inpatient case I'm going to relay to you, but this is a 10-month-old who was seen in our hospital, in our children's hospital, admitted for a right parietal skull fracture and a small subdural hemorrhage that was focal. So it was associated with the skull fracture after an alleged fall. And at first glance, that seems fairly plausible. You know, a fall can cause a skull fracture with a small subdural hemorrhage associated with that. So what on physical exam, what was documented is there was a very active child. He was cruising, by the way, and I actually saw this as well. He was an incredibly active baby. There was right parietal swelling, which would be associated again with that skull fracture. So very, again, what would be expected. But when I was called by the floor team, I was notified that he also had a little bit of bruising to his chest and to his right knee. And, for his age, even though he's cruising, that would still be a little bit of a concern. In the meantime, the trauma team had seen him, and they essentially did a head-to-toe examination, but no other testing because he looks great. And that's what I was told, is he looks amazing. And again, when I saw him, he really did look amazing. So I was eventually consulted, luckily, and through that standardized workup that I talked to you about, so those labs and those x-rays, we were able to uncover a few things. One of the things I always check for are liver enzymes on any child that's coming in, especially into the hospital, but even in through our clinic. And if those liver enzymes are elevated, that raises my concern for an intra-abdominal injury. And in this situation, his enzymes were about 3 times normal. So we went ahead and did a CT of the abdomen. And just to give you a little bit of orientation, these white things here are ribs. So this is a cut essentially through the center of the abdomen, cutting him in half kind of top to bottom, if that makes sense. This big piece here is the liver. This is a kidney. This is his spinal cord in here, and then the vertebra. This piece over here, this is the spleen that I've outlined in pink. And normally the spleen is going to be almost all white. So interesting that we have this big gray slash through the spleen. And what that represents is he actually had a fairly severe splenic laceration. Okay. Luckily, that laceration did not require any kind of surgical repair. What we also saw from another view on the CT scan, and this is what we call a coronal image that kind of splits the body into front and back. So this is the heart. This black stuff are lungs. These are ribs. This is the liver again. This should be black here. So what we're seeing, this gray stuff, where lung should be, is actually blood accumulation around the lung, or what we call a hemothorax. So this child actually had a clinically significant finding, even though he looked amazing and his physical exam was essentially normal. His lung exam was normal. He did, well, and I'll get to this in a second, but he did require a PICU admission for chest tube placement. But then on his skeletal survey, we also were able, and on his CT scan, we were able to find 11 more rib fractures in different stages of healing. It's more likely than not that the rib fracture is what caused the hemothorax, but we'll never know 100% for sure. So again, like I said, this was medically significant. And the point I want to drive home again is, even if the child looks really good, I think we have to consider what might be underlying, and at least just to do some very cursory things to hopefully rule out any further occult injuries. And this is where that standardized exam is very, very important in the work that we do. This is my favorite case. There's a medical explanation. So we saw, an 8-month-old male who was admitted into Marshfield Medical Center's pediatrics unit. And this child presented initially with a very large ear hematoma. I think you all can see that this is the earlobe, and this is a very big swelling of the pinna of the ear. You can even see a little laceration here where the child had been lanced, or they had attempted to lance the ear, and the blood had just reaccumulated. We also saw on his exam some bruising here under his mandible and some bruising along his forehead. And I don't have the picture with me, but also he had some buttock bruising. The parents gave a story that essentially he had been hit in the head with a coffee table that rotated. Couldn't quite figure that one out. So the floor team was evaluating this child, the hospitalist team, and they did some lab workup. And so PTT and factor VIII are both tests looking for bleeding disorders. And they were elevated, they were abnormal, and so they were able to do some mixing studies and find that this child had hemophilia A. The problem for me is that hemophilia does not normally present with ear hematomas, and so that was an issue, and it raised a red flag. They had originally consulted me, but then canceled the consult because, as they said, we don't need it, we have a diagnosis, and that was literally what I was told. I was told to go away, and I asked them, please, if there's any concern, just get a skeletal survey. They did not. He was discharged home. 12 days later, he returned to his primary care doctor's office with right arm swelling. So you can see where this is going. This is the x-ray of his arm and elbow. And you can just make out right there at essentially the distal portion, or the end portion of the humerus, is that little line there is actually a fracture. Not only that, we were able to we actually ended up transferring him back to Marshfield Medical Center, and there we were finally able to get a skeletal survey on him. In fact, we did both skeletal surveys, and we found several things. We first found an angulated fracture of the left radius. And this is a healing fracture. This is an older fracture. We found a right tibial fracture near the ankle, what we call a classic metaphyseal lesion. He also had the same type of lesion on the left ankle or the left tibia, and then fractures in the long bones of both his right foot and his left foot. So I think, again, that's very significant. And what I try to, again, press to the clinicians that I work with, because I do hear this often from them, is even though you have a medical diagnosis, if there's something that's just not quite right, we should at least look into it and rule out any other occult injury and hopefully rule out abuse as a mechanism. So another thing that I hear as well, that mechanism fits or that makes sense. So I don't think that we need to do a workup. We had a 15-month-old female, and this was a little convoluted. She was at her daycare provider's home when she, quote, slid out of her high chair onto her butt and became symptomatic at the daycare provider's home, had what was described as labored breathing and choking. And that was reported from the daycare provider to EMS when she called. So it was scary enough that she made that phone call. EMS did arrive, and interestingly, though, they documented that the child was lethargic, so her mental status wasn't quite right. But then they also went on to call her asymptomatic, which that's kind of it doesn't really fit. Unfortunately, the child was not transported to any medical facility at that time. Mom and Dad did arrive at the scene and essentially took her home too. And at home, she was described as sleeping a lot more than usual, and she started having some episodes of vomiting. So because of that, they then brought her into the local emergency department. And there, they did a CT scan because she wasn't acting quite right in the history of vomiting and the history of the fall. And they found a subdural hemorrhage. She was then transferred to our facility for higher level care and went into our pediatric ICU, so the PICU, for stabilization. Their physical exam, though, in addition to the subdural hemorrhage, was also significant. This child also had bruising to her cheek, and I think we know that those fleshy parts of the body don't bruise quite as easily, and there was no mechanism provided for that at the time. She had bruising of her ear, which is one of those areas that we wouldn't typically see accidental injury. And we also saw a frenulum tear of the upper frenulum, the upper mandibular frenulum. Upper maxillary frenulum. So I was, of course, this always seems to happen. I'm always out of town when these things come in. But a report had been made to law enforcement and to Child Protective Services. I don't know exactly how that report was made or what information was given. But when I believe when they heard that she had slipped out of her high chair and possibly hit her head on the footrest of the high chair, they felt that was plausible. And so I was told by Dad later that he was called by law enforcement, and they basically asked him, what do you want us to do? This story fits. And truly, CPS screened this case out, and law enforcement closed this case within 12 hours. And then I returned from my vacation and was able to do a consult on the child. And so when I talked to Mom and Dad, I got a little bit more history. Not only did we have the acute injuries noted on her physical exam and the subdural hemorrhage, there was also this history of, well, she came home all the time with bruising of her ears, and she came home all the time with busted lips. And so I felt like that there was a chronicity here of frequent injuries in that daycare provider's home that were very suspect for inflicted trauma. So I personally, my team and I, re-reported, and we were able to talk at length with CPS about this. And I think what had happened in the beginning is there was a miscommunication as far as the injuries and the significance of the injuries, unfortunately. And so when we re-reported, the case was opened, which was great. And interestingly, though, the following day, I got a phone call from the CPS worker basically asking me if I remembered a name, and she gave me a name and then told me that that was the name of the daycare provider. And I said, yes, I do remember that name. Why? She said, well, 2 years ago, you saw a child from this daycare center with almost identical injuries. So we had 2 cases now of potentially abusive head trauma, or at least physical abuse, coming out of this daycare center. And interestingly, once this case went live, once it was reported on the news media, multiple families came out of the woodwork to state that their children had been incurring injuries while in the care of this individual. So this was almost a missed opportunity. Luckily, it was not, but I think a lot of assumptions were made. And again, we need to dig a little bit deeper when we hear these mechanisms, because again, if we're not witnessing that mechanism, if we're not seeing it firsthand, how do we know that that's actually what happened? All right, just a couple more cases, I think, here. So I hear also that many times we'll get calls to do a forensic interview on a child for sexual abuse, let's say, and but they don't want a medical. Well, the contact was a long time ago. We don't need that. There's no reason to do that. We had a 6-year-old female who had come in, again, with that concern of sexual abuse, and it was a delayed disclosure by a few months, as a matter of fact. When she came in for her forensic interview, she did give a disclosure of sexual contact, but stated that it was only over the clothes and only digital. Since I was already kind of queued up for this, I went ahead and did the physical exam, and her exam was completely normal. But when we got her urine back, she actually was positive for chlamydia, and that doesn't come from over-the-clothes contact, I think, as we all know. So this was, again, almost a missed opportunity. And so I also hear a lot of times we'll get an exam if the child discloses or if they disclose significant contact. And so we could be missing information if we're not looking at the physical piece of this when there's a concern for sexual abuse. All right, my last case for this section is I just need hair testing. This one I hear a lot. We'll get a call about a drug-endangered child, and we just want to get hair testing. We just want evidence that the child's been exposed to meth or heroin or whatever it is. And my point is, I think there's so much more that we can offer in these cases. So this is just one of many examples that I have. We do a lot of DEC cases here. This was a 2-year-old male that was seen in our local emergency department at the time of the search warrant execution after he was removed from his parents' care. And there were concerns for exposure to toxic substances, of course. He was later then brought to our facility for, again, for those concerns of drug endangerment. We had no medical records on this child. All we could go on is what the foster caregiver had reported just in the short time that she had been with this child. But she was able to tell us that in that, I think he had only been in their care for less than 2 weeks at that point. But there was a significant language delay reported at this point. This child was actually self-harming at 2 years of age. But he was also what she called spacing out. So he was likely dissociating, especially when things were becoming stressful, and had absolutely no boundaries in that he would run up and hug everybody and anybody, just trying to bond with as many people as possible. So generally when we do these exams, the exams are typically normal. It's all of the history that we get from the families that's very, very significant. We do some lab work looking at nutritional status, and he had what's called a prealbumin of 14, which would suggest some protein malnutrition. So maybe some poor diet or just lack of food or lack of high quality food in general. And of course, we did hair toxicology testing because that's the only reason why he was really brought in the first place. And he was positive for methamphetamine and metabolites of that, metabolites of cocaine, and also THC. And so, you know, we could just focus on this piece. Yes, he's had some sort of exposure. We can't tell you exactly what type of exposure he's had or how long he's had it or how much he's had. And yes, this exposure could potentially cause other problems. But what we tend to see more frequently is that these children coming from drug-endangered homes are also coming from very neglectful homes. There just isn't the care and nurture that's required for these children to grow and develop normally. And so with this child, based on the history as well as the exam and the lab work, we were able to say that he is a drug-endangered child, of course. He had global developmental delays based on our assessments. He had obviously self-harm behaviors and possible dissociation, protein malnutrition. And this is really a function of not only that environmental neglect, but also likely emotional neglect. And so when we're looking at these drug-endangered cases, yes, we're looking at the neglect piece of the exposure of the child to the drugs, but also we can be looking at the psychological harm that's being caused to children when they are in these very chaotic and neglectful environments. So in a nutshell, when should we be getting an evaluation? And I think at the very minimum, right, any infant that has a visible injury, so any child under 12 months of age with a visible injury should be evaluated by some type of medical professional. Any child with a severe or patterned injury, any child with urgent or emergent needs, whether it's based on the injury or if there's other things that are found. If you have injuries that don't have a plausible explanation. But we have to be careful about this as well, because again, sometimes explanations can be plausible, but if we didn't witness it, how do we know that that actually happened? If there's a disclosure or if there's a significant concern for sexual abuse, I think evaluations should be sought out. If there's a concern for infection, pregnancy, or genital injury based on history. And also, I like to say that really any child being pulled from a drug-endangered home deserves some sort of evaluation, because not only do we want to look at the pieces of, their likely exposure, but knowing that a lot of these children also just don't have good medical, they don't have solid medical homes, and in many cases they haven't had medical care in a very long time. But I'm also going to go ahead and say, and some of you would probably disagree with me, but I'm going to stand by it, is that really we should get an exam, or we can argue that every child who has concerns of abuse in some way really deserves a medical evaluation. And again, it can be for that forensic piece, but also to ensure their overall health and well-being. All right. Any questions?
No questions.
All right. Hopefully not everybody's bored and falling asleep. All right, moving on. This is the last piece. So the third question I want to answer, who do we need to seek out for these evaluations? We have multiple levels of providers that we can see. And by the way, I want to say one thing. By no means do I mean to undermine the care of other clinicians, because we all have a role in these cases. And I truly respect my colleagues in general pediatrics who see these cases when I'm out of town or whatever. So the general practice, so whether it's a primary care provider like a pediatrician or family practitioner, or a nurse practitioner of some sort, a doc in urgent care or in the ED, there is utility in using any of these professionals. And of course, part of it is, who's closest, who's easiest to access. You may not have access to a specialist in child abuse medicine. So definitely any medical is better than no medical in my mind. But a couple things to think about, especially with that general practice in the ED clinicians, is that they tend to have less training in the areas of child abuse and neglect. They tend to have less levels of comfort because of the lack of training and also the lack of experiences. And something, too, that I think is taken for granted is that many of them don't have a significant amount of time to see patients. Most of our pediatric colleagues upstairs, and I say upstairs in the clinic, they only have about 15 minutes to see patients. We take up to 2 to 3 hours in some of our evaluations. So that's, obviously a huge disparity between what can be offered through a child abuse clinic, essentially, versus what can be offered in a more of a general practice. Sexual assault nurse examiners, again, a very valued component to this team. And so when there are concerns for sexual abuse, especially if the contact occurred in less than 5 days, that is a wonderful resource, and they are absolutely the experts in that forensic evidence collection. But we have to keep in mind, too, that nursing licensure does not generally allow for diagnostics. So if there are findings, really those findings should be confirmed by a clinician who is licensed to diagnose. So whether it's a physical finding of potential blunt force penetrating trauma, or signs of infection or other things, that really should be followed up. And of course, then there are our CAN experts. Myself, I'm a pediatrician that specializes in child abuse. And then we have our docs down in the Milwaukee area, essentially, who are, I believe, almost all are fellowship trained and board certified in the area. And again, what we offer that's a little bit different is that extensive training, years and years and years of training in some cases, and then the extensive experiences. You know, I've now seen over 1,000 cases of child abuse in the 10 years that I've been doing this. And so we've come across not all scenarios, but most of the scenarios at this point in time. We also have extensive knowledge of the literature around child abuse and what is or is not kind of valid explanations for some of the things that we're seeing. And then there always is that testimony piece too. When you're in court and you're testifying to these things, it's very helpful to have a number of court cases under your belt to feel very confident in what you're doing. Oh, sorry, my computer's frozen. So just a couple of studies to present, just to kind of drive this point home a little bit. One study that was published back in 2009 by Wendy Lane and Howard Dubowitz looked at just surveying pediatricians in general about their experience, their comfort, and their competence in doing any type of child maltreatment evaluation or workup. And what they found is that when they surveyed almost 150 pediatricians, that many of them, or most of them, felt competent in performing the head-to-toe examination. But unfortunately, they did not feel competent in actually giving you an opinion as to whether the findings were consistent with non-accidental trauma, or not consistent with, I should say. They also had little confidence in their ability to go to court and testify to these cases. Speaking now specifically about child sexual abuse, another study that was published in 2005 by Ann Botosh and her colleagues essentially looked at providing training to general clinicians in the evaluation and interpretation of child sexual abuse cases. And what they found, though, is that of the, I think there were 64 medical providers that actually that participated in this study, and they were each essentially given 21 hours of training, and then a pre and a post test were taken. And even though there were overall improvements in their pre and post test scores, about 60% of the clinicians did not correctly interpret exam findings when they were tested on that. And so when they're looking at genital findings, they were not able to say whether something was a laceration versus a normal congenital finding. Almost 30% did not provide appropriate reassurances through that testing when they were asked about how they would do that. And almost 40% didn't understand some of the legal implications to the information that they had obtained. And so this is important, again, for not only, I think, helping our cases move forward, but helping the child and their family heal through these very stressful times, and then how this plays out potentially in when it comes to courtroom issues. So why should we be seeking expert evaluation? Again, that training and experience is so important. Again, you know, I forget how many patients Dr. Sheets has said that she's seen, but I'm sure it's in the probably close to tens of thousands at this point in time. And that just speaks volumes to what is able to be offered in these cases. We also have confidence in what we're doing, so we can speak to it, again, whether it's in front of a judge or in front of a family or in front of, you know, other experts in this area. But we also come to it, I think, with an air of objectivity, where a lot of my general pediatrics colleagues do tend to get a little more emotional about these cases. We can come in and talk specifically about the injury findings, what those findings mean, and move forward with that. I mentioned timing before because, again, most of my general pediatrics colleagues only have about 15 minutes. I'm able to spend 2 to 3 hours with my cases if necessary. And so we do give it the time and attention that they need. Additionally, the staff that I work with also have the same abilities. The medical assistant that works with me spends hours retrieving records and combing through those records with me. So the documentation we provide, I think, is very high quality in general and very descriptive. And sometimes, and again, not to throw any stones, but I think sometimes we'll see from general practitioners, they'll document, for instance, bruises to the face. Whereas when we talk about bruises in our documentation, we are specifically describing each and every bruise, describing the size, the shape, the color, the texture, and the blanchability of those bruises. So there's a lot more, again, tangible information coming out of that documentation. When you seek out a child abuse expert, chances are you're going to be bringing that child to a place where there's other tertiary care services. And so we do have access to other specialists if needed. I think one of the ones to drive home is, for instance, when we're getting radiology examinations, we have specially trained musculoskeletal radiologists who are very adept at picking up those occult bony injuries. Unfortunately, when we've had x-rays read by outside radiologists from other systems, injuries have been missed in the past. And so if you do want that high quality, I think, again, coming to a tertiary care center at a minimum, but one that has a child abuse expert is important. And the last is access to resources for the child and the family. So we tend to work with, we have our own social workers here on our staff that can speak to any basic needs that are missing for the family to help them get through this time, and then also helping aligning them with other community resources to move through the process. Okay. So just to speak to, again, why it's, I think, important to have a child seen by an expert, and at a minimum, if you're going to take a child to a general practitioner or to a SANE evaluation, I think there are instances where the expert should still be employed. And this is a 5-year-old female. This is, again, a little convoluted. But she was originally seen through the Marshfield Medical Center by one of our SANE nurses. And there was, again, concern for sexual abuse by a caregiver that was reported at the time that she was being seen for her SANE eval. And that SANE nurse did her examination, and on that examination, she documented a tear, and I put that in quotes because that's the terminology that was used. And that tear was noted at the 6 o'clock position. So when the child's laying face up on the genital, on the vulvar area, in the perivaginal area, there was some sort of lesion at the bottom of that perivaginal region. She did come to our CAC 2 days later. At that point, unfortunately, nobody knew about this tear. Nobody in my staff knew about this tear, but she did have a forensic interview, and there was a clear disclosure of sexual contact that was made, in fact, very specific, and penetration as well. So we received a call, again, about 2 weeks later. So she had been sent for follow-up by the SANE nurse. She was being seen by her primary care provider, and there were concerns for discharge. And testing, as per their protocol, had not been done at that time, or at least not that we could find in the documentation. So we decided to bring her back for the concerns of the discharge as well. And so at this point now, my medical evaluation was scheduled. So when I saw her, I was not, well, when we took the original consult, I was not originally aware of the injury. And so it wasn't until we were able to retrieve that documentation that we saw that there was an injury noted, which obviously raised significant concerns and for me, because I wanted to make sure that that we were evaluating that appropriately. Again, during my medical evaluation, she disclosed sexual contact, and she was very consistent with what she had said during her forensic interview. But during her physical exam, I noted the lesion that the SANE nurse had seen. I was able to evaluate the SANE nurse's photographs that were taken at the original eval, and there was a lesion noted at that same 6 o'clock position. But that lesion in the original photographs was not acute. And when I saw her 3 weeks later, that lesion was completely unchanged. So as I had done looking a little deeper into her exam, essentially, what I found is that this actually was more of just a congenital avascular region in that perivaginal area. So it wasn't an injury after all. And I think that's important too. And because the last thing we want to do is make a statement about an injury occurring, and then if that goes into the courtroom and then it's proven that it's wrong, I think it unfortunately undermines some of the work that we do. So we have to be very careful. And so to this point, I would say that, when we do have these cases where there is an injury noted, especially on a sexual abuse evaluation, that an expert should be seen or should be consulted. So I'm just on my last couple of slides here. So when should we be consulted? I think for physical cases or physical abuse cases, when complex injuries are present, yes, we definitely should be consulted when you're trying to pull together information about different types of injuries that are in different parts of the body. I think it's very important for an expert to be brought in for that. If you need confirmation, so if there is something that's likely an injury or concerning for an injury, but the clinician isn't quite sure, I think that would be an appropriate time to have an expert brought into the case as well. And, obviously, if there's court testimony, I think it's important to have that level of expertise speaking to the findings in the courtroom. But again, just like before, I'm going to say that truly, I think that as often as you can, trying to employ an expert in these evaluations, because there is so much more that we can offer, I think, than our colleagues are able to because of timing and because of their level of expertise and training. So to conclude, last slide, I think all of us agree that medical providers are an integral part of our multidisciplinary team. I think, and so I've never questioned that. But sometimes I do feel that decisions are made for us as to whether a child should be seen. And I think it's appropriate that, we talk to the clinicians to find out whether they think an evaluation should be performed or not. So these medical exams that we have provide, again, important information for the investigation to further the case along from that forensic information collection. But we also should have that goal of making sure that child overall has good health and that we're speaking to their overall well-being as well. Really, I urge you to have a lower threshold for obtaining a medical exam and expert consultation. I think that's the last one. And, again, based on availability, based on resources, based on timing, that you may not be able to have a face-to-face with a child abuse pediatrician, but phone calls can be made. I know I take phone calls from anybody that calls, to help, or emails for that matter, to help kind of weed through any questions or concerns. And I don't want to speak for anybody else, but I have a feeling most of my colleagues around the state would do the same thing. So. All right, any questions?
Yes, we do have a question. At what point do you decide whether or not a thorough medical evaluation will or will not be more traumatizing than necessary?
That's a really good question. And I think you're probably referring to sexual abuse evals, but I don't want to make too many assumptions. So I'm going to speak to sexual abuse first, and then I can speak to other exams. When we do our physical examination in our child advocacy center, though, if you're taking a child to a place that truly is trauma responsive and trauma sensitive, we tend to do things a little bit differently than a general clinic. So we, for instance, employ child life specialists to help with distraction. We just use a lot of other methods to help keep a family and a child at ease through that entire process. So if you're going to a CAC, for instance, that has medical, that has the capability for medical, chances are things are going to be done in such a way that it will be very minimally traumatizing. And we also know that, as physicians, I just had a couple of cases yesterday where two sisters they weren't going to have the examination, and we opted out of the examination because we did not want to further traumatize them. But in general, we're very good at getting those exams done because, again, we are pediatricians at heart. We know how to communicate with children. We can connect with them and put them at ease. I'm not sure if I actually answered the question. I feel like I answered around it.
Great. And one more question. Are child abuse and neglect exams covered by patient insurance?
Yes.
Okay.
That's 100% yes. So, we have not had a problem here at the Marshfield Center having things paid for. I think the one time we did have an issue is because the family had commercial insurance and they had a relatively high copay. So unfortunately, in that situation, the family would be responsible for it. But then there's also, other resources that can be used to help, and we do employ those when we need to. Most of our families are on Medicaid or Badger Care, and Badger Care will cover everything 100%.
Last question. Oh, sorry.
That's okay. Go ahead.
One more question. How can we locate a qualified provider to have these done in our area?
Well, that's a great question too. Elizabeth, do you have that information on the CAC, the chapter website?
We have the CAC information on the chapter website, and certainly I would say if there is a child advocacy center in your area, reach out to them first and see if they have any resources.
Exactly, that's what I was going to say. And if they don't have direct resources within their CAC, they will likely know of the closest provider for you. So that hopefully that helps answer that question.
Great, thank you. I'll ask you to leave the attendance slide on the screen for a couple of minutes. Attendees, if you have not already done so, you may now text the attendance code and complete your evaluation. Please join us for next month's webinar, Ingestions in Children, Accidents or Abuse, presented by Matt Torbenson and Hillary Petska. Thank you for being with us today.
Thank you. Thanks, everybody.